Good morning, everyone. Yeah,
Hello.
good morning, everyone. So we are starting with a National Physiotherapy webinar on physiotherapy in breast cancer rehabilitation. This is our fourth webinar in the series, and today we are discussing a very unique topic, and to give a brief idea about our institute, Composite Regional Center for Skill Development, Rehabilitation, and Empowerment of Persons with Disabilities is a central government institute under Ministry of Social Justice and Empowerment, Government of India. And we have various departments in our institute like physiotherapy, occupational therapy, special education, audiology, speech language pathology, uh, prosthetic and orthopedic unit, social work unit, and we are running various diploma courses and certificate level courses. And myself, Binoy Matthew KV, is leading the physiotherapy department with the support of B. Marimutu and Fatima Sumaya. And now I invite Marimutu to introduce the resource person of our day. Over to you, Mari.
Good afternoon, friends. First of all, I welcome you all for this national webinar. Today's speaker is about Mr. Gnanashekhar. He has graduated from the Tamil Nadu Dr. MGR Medical University with a bachelor in physiotherapy. He is a certified lymphedema therapist from Academy of Lymphatic Studies, USA, licensed by Lymphology Association of North America. He has done his oncology rehabilitation certification from Postgraduate Allied Health Institute in Singapore General Hospital. He is practicing onco rehabilitation and lymphedema management since 2010, and he is a pioneer in establishing the first dedicated lymphedema clinic for breast cancer survivors in South India. Gnanashekhar sir holds professional associate and overseas membership from Indian Association of Physiotherapy, Singapore Physiotherapy Association, Canadian Physiotherapy Association, and Association of Chartered Physiotherapists in Oncology and Palliative Care of UK. He has organized several international workshops and conferences in association with international physical therapists for HIV, oncology, hospice, and palliative care, lymphatic education, and research network and international lymphedema framework. Gnanashekhar has been an invited guest speaker in several national and international conferences and workshops, including the most recent in Rajiv Gandhi Cancer Institute in New Delhi. We welcome you, sir. I request all the participants to mute your mic and also your video. And I'm handing over the session to Mr. Gnanashekhar, sir.
Hello. Am I audible?
Yes, sir. You're audible.
Okay. So, myself, Gnanashekhar. I'm a physiotherapist basically, but I'm practicing more and more in oncology. I'm specialized in oncology along with that lymphedema management mainly. So I want to thank Mr. Binoy Matthew sir, the HOD of Physiotherapy Department of CRC Kozhikode, and Marimuthu. So he is an senior to me in my college. I want to thank them to give me a chance to present this, to enlighten you people with what is about breast cancer rehabilitation, the topic that is not mostly touched. So shall we move the topic then? Whether we can share the slides.
Yes, sir. Just one second.
So at the end of the session, we will be having some question and answer sessions. So you can ask your questions. So I like to So as many as questions as possible you can ask, so that I will take my maximum to explore you these things.
Hope you can see the presentation, sir.
Yes, sir. Done. So the topic we are going to discuss is about the role of physiotherapist in breast cancer rehabilitation. So when it comes to oncology, the widest thing what we understand is any physiotherapy modality is being contraindicated for oncology patients. So that is what we taught in our early days. But even that, we have a major role in rehabilitating the patients who are undergoing an oncology surgery, radiation, chemotherapy, any kind of management. So we have a very big major role to play in it. So next slide, please. Next slide, please. So in this session, we will have a debrief about what is breast cancer, what are the causes and the risk, and what are the symptoms of breast cancer, what is the early detection and the treatment methods, and what are the complications of treatment following either it is following chemotherapy, radiotherapy, or even surgeries, and what is the role of physiotherapist in breast cancer rehabilitation. So this is the overview that we are going to cover in this session. Next slide, please. So what is breast cancer? So breast is primarily affects women, but 1% of all cases affects men. So breast cancer is a common cancer nowadays in women. Breast cancer is the second leading cause of death in women next to lung cancer. 1 out of 9 women in US will develop breast cancer in their lifetime. 1 out of 20 in 1960. An abnormal uncontrolled cell growth arising in the breast tissue. So when we take the difference in Indian scenario and in foreign scenario, in Indian scenario, the patient comes to the surgeon or an medical center with an advanced stage because we are not having this early screening. But in other countries, they have the screening for breast screening in their insurance itself. So that is the major thing that we have a drawback in India. So when the patient comes to the clinical setup for evaluation for their breast, it is very less in India. Only after they have a lump or anything, so they are coming to the clinic. So that is the very big issue that we are having in India. Next slide, please. So breast consists of many fatty tissues interspersed with connective tissue. There are also less conspicuous parts like lobes, ducts, and lymph nodes. So these everything together we call as an breast. Next slide, please. So breast as a gland. So each breast has 15 to 20 sections of lobes that are arranged like petals of a daisy flower. So inside each lobe, there are many smaller structures that we call as lobules. So at the end of each lobule, there are tiny sacs, or we call it as bulbs also, that can produce milk. So this is as of a breast gland. So next slide, please. So lymphatic system. The main important system which comes for an first line of defense is the lymphatic system, because in lymphatic system it not only drains the excess fluid that is left out by the venous return, but it also acts as a defense mechanism also. So we should have a wider knowledge about the lymphatic system when we are going to address an breast cancer patients, because lymphatic ducts drains fluids that carries the white blood cells from the breast tissues into lymph nodes under the armpit and behind the breastbone, and these things are carried towards the lymph nodes, that is towards the axillary lymph node, to filter the harmful bacteria or viruses that plays a key role in fighting the infection. Next slide, please. So what are the causes? So the majority causes is unknown, and the hormonal thing, the hereditary, obesity, lifestyle, and prior radiation to the chest wall. So these are the main causes for breast cancer. Next slide, please. So, what are the signs and symptoms? The most common signs and symptoms will be the patient will have a lump or thickening in the breast, and more often it will be painless. And the next click. The next will be a discharge or a bleeding. So any unusual discharge or a bleeding in the nipple or areola. Next will be the change of the size of the size or the contour of the breast. When you compare the left and right breast, usually there will be an mild non-similarity. Either the right or left, either will be in bigger size or smaller size. But particularly in cancerous conditions, the size will be altered varily. Along with that, the texture and the contour, how we feel while we are palpating, how we feel, the thickening and everything will be changed. So next, please. And change in the color of the appearance of the areola. So either it may be an pinkish thing, or the pinkish thing might be converted into a dark brownish colors, or a pale white thing, and some redness or some pitting over the skin, like an orange peel, like something. So these are the main signs and symptoms of the breast cancer patients. Next slide, please. So what are the non-cancerous conditions, but they will also have the same signs and symptoms. In fibrotic changes, so lumpiness, thickening and swelling are often associated with the women's in period. When they are in their menstrual cycle, on that time, the women may have a thickening or a swelling in the areola, and some lumpiness will be there, and some cyst, fluid-filled lumps, and range from the very tiny for about the size of an egg. So these are some cysts that will mimic the same signs and symptoms of a cancerous thing. And in fibroadenoma, a solid, round, rubbery lump that moves beneath the skin when touched, occurring most of the young women. So many young women will have these kinds of things, but what they will think is they are having a lump. But when we go and when we go for a screening, then only we can able to distinguish these things. From when in some cases of an infectious things, the breast may become somewhat red, warm, tender, and lumpy. So this is maybe due to this erythematous things because of the infectious part. Either maybe a trauma or a bruise. Anything may be the cause of it. Next slide, please. So this is how the tumors will grow. So first it starts in the breast, in the tissue, then slowly it will get into the duct, and these things goes towards the lymph vessels. After reaching the lymph vessels, it will go towards the lymph nodes. So this is the normal mobility of the cancerous cells in the breast. Next slide, please. So this is how the metastasis of the lymph node will occur. First, the node will be normal, lymph nodes will be normal. Then after the phagocytosis and the distribution of the nodes, after the cancerous cells are present, it will slowly widen the part and slowly it will get metastasized, and at last the entire lymph node will be compromised. Next slide, please. So this is the anatomy of the chest wall that we have to know where the lymph nodes are located, because this tells us what are the lymph nodes that are possibly removed during the surgery, because we have many levels of clearance for the lymph nodes, level 1 clearance, level 2 clearance, level 3 clearance likewise, so that we should have a broader knowledge about the presence of lymph nodes, where the lymph nodes will be present, like axillary level, central axillary level, subclavicular nodes, supraclavicular nodes, interpectoral nodes, internal mammary nodes, scapular nodes, external mammary nodes, abdominal nodes. These kinds of nodes are there. It is not only that the entire breast tissues are going to be drained only in the axillary lymph node. All the things will also drain in the other adjacent lymph nodes also. So we should have a broader classification of nodes, because when the patient develops a lymphedema or anything, these nodes plays a major role. So where we are going to reroute the fluid. So next slide. So what will be the complications of a breast cancer treatment? So usually after diagnosing for breast cancer, the patients will go for a chemotherapy, radiotherapy, or a surgery. So these will be the main line of treatment. So it depends upon the patient's conditions, whatever treatment the patient may be undergoing. But the commonest complications the patients will get after chemo, after radio, after surgery will be these things. One is breast cancer related lymphedema. The second one will be the axillary web syndrome. The third will be the post mastectomy pain syndrome. Then shoulder dysfunction and bending of scapula, etc. So these are the main complications that the physiotherapist, as physiotherapists, we are going to address. So we'll go for axillary web syndrome. So axillary web syndrome is also called as lymphatic cording. So it is mainly due to the thickening of the lymphatic vessels, right? So it will be a lymphofibrotic in origin. So it will mainly happens in the skin, in inner arm, medial aspect of the arm, antecubital fossa, wrist, thumb, and chest wall. So this is the line where you will see the web syndrome. Next slide, please. So when you come to the pathophysiology, as I told, it is an angio, lymphatic, and fibrotic in origin. So the lymphatic channels are compromised, and the tightening of the adjacent surrounding tissues, it is mainly happening because of the radiation. Because when the radiation is applied to the chest wall, usually what will happen is it will shrink the skin. Along with the skin, the lymphatic vessels will also be shrinked. So this is the commonest thing. Like that of we are throwing a polythene car into an fire. So what will happen? It will just shrink. So that is what happening in the lymphatic tissues. So most of the patients will have developed axillary web syndrome during radiotherapy. So the prevalence of axillary web syndrome is 85% of the breast cancer patients. Either it is an anterior lymph node dissection or a sentinel lymph node dissection. Axillary lymph node or sentinel lymph node. Either lymph node dissections, but the prevalence is higher rate. So what will be the management for axillary lymph node reduction? So what we call as an DAP. DAP is nothing but a dynamic angular petrissage. So it is a technique where we are going to knead the muscle slowly as a segmental thing. So we are not going to stretch the entire lymphatic channels. That is a line of lymphatic channels that I told you, right? From the cubital, from the wrist, base of thumb, wrist, cubital fossa, inner arm, and chest wall. So this will be the line where the tautening of the lymphatic channels will happen. So now we are going to slowly knead the muscle as a segmental pattern. So if this is the skin, we are going to slowly knead the muscle and we are going to slowly stretch it as a segmental pattern. We are not going to stretch the entire part all of a sudden. We are just going to stretch it segment wise, like this. Slowly, this one segment and next and next. This is followed with the kneading technique. In exercise therapy and massage, we will be doing this kneading, right? But in this management of axillary web syndrome, we are not supposed to go in depth. So it is not an hard in-depth kneading, but we have to address it as a superficial layer. Okay. So along with kneading, we should ask the patients to passive or actively assisted, and we are going to move the patient's arm. That is either extended and stretched likewise. So while we are doing like this, the muscle stripping will takes place. We will hear some individual noise like tuck tuck tuck. The sound will happen because that sound is what the stretch applied, what we apply to the patient, which creates this lymphatic channels to stretch and open. Okay, and it will be very, very painful. It's same like of a myofascial release, but like a segmental thing, but not a full myofascial release. Okay, and it will be very much painful. And even the patient, I have seen some of the patients has even fainted during stripping the lymphatic channels. So what we recommend always is after MLD, after manual lymphatic drainage, always we will do this DAP after the manual lymphatic drainage. So I will tell you what is manual lymphatic drainage in the later slides, but this has to be done very with a high level of precautions, because the patients will have a high level of pain due to this all radiation thing and medications. The patient will be having a tendency to pick up pain impulses more. So we should be more careful about doing these things. Next slide, please.
Excuse me, sir. I request all participants to ask your queries at the last of the webinar, at the end of the webinar. Thank you. You can continue, sir.
Okay. See, this is how the post MR, modified radical mastectomy scar will be. You can see, right? The scar has been extended from the mediastinum, that is near the sternum, towards the axilla. So it is an horizontal insertion, right? So the entire part will have a tightness. So this is just an patient after undergoing an MRM. Same thing will be happened even after the patient is done with the radiation. See, the patients may go for an radiation after surgery, or first radiation, then they may go for a surgery. It depends upon the surgeon and the stage of the patient, on the stage of the cancer what they are in. Next slide, please. Okay, in radiation therapy, the position that we are going to adapt during radiation therapy will be this position, right? This position. Okay, so next slide, please. So when the patients are unable to lift their arm and get to the optimal position for radiation, so you can see, right, how the beam is passing. The beam is passing and it is covering the entire breast. But see, this is the optimal position. But when the patient fails to hold the arm like this, that of an radiation fibrosis, if the patient has a radiation fibrosis or an axillary web syndrome, the patient is not able to entirely stretch the arm because of the tightened lymphatic channels. They will have an excruciating pain. So this will restrict the patient's movement. Okay. So when we are unable to attain the full movement, right? When we are unable to attain the full movement, we will be irradiating the unwanted part. So rather than irradiating the specific part that is to be radiated, we will be the other parts will also be held for irradiation. So this is the main reason that we should have a look on the axillary web syndrome and clear it, because the patients will, next slide please, because the patients will have an about 72 cycles for 72 cycles fractions for radiation also. By meanwhile, the patient may develop axillary syndrome in the very 15th cycle or 20th cycle also. So if the patient is unable to lift the entire arm and hold the position for radiation, then the other fractions of radiation that we are going to give will be injuring the patient's other adjacent parts which are non-cancerous thing. So that is the main reason that we should address on axillary web syndrome, and we should clear the axillary web syndrome so that the patient has a full range of motion, so that the patient will have an effective radiotherapy. Next slide, please. So the next commonest problem that the breast cancer patients will be getting is then breast cancer related lymphedema, right? The breast cancer related lymphedema can be because of various causes. Either it can be because of an surgery, because during surgery we will remove the axillary lymph nodes, right? The main lymph nodes where the um, lymphatic things are going to be drained, right? That may be one reason. The second reason may be due to the radiation fibrosis. Because of the radiation fibrosis, the lymphatic channels will be shrinked. So because of this, the transport capacity will be reduced and there will be an large lymphatic vessels, due to which the edema may occur, right? So breast cancer related lymphedema is a prevalent complication secondary to cancer treatments, which significantly impacts the physical and psychological health of breast cancer survivors. Every breast cancer patient is at a lifetime risk of breast cancer related lymphedema, and the risk goes on increasing as the follow-up of period increases, right? Because even after the surgery or after the removal of the lymph nodes, all the patients irrespectively, after the removal of lymph nodes, all the patients irrespectively have a tendency to develop lymphedema, right? But some people will develop the lymphedema at a later stage, like 10 years or 15 years later also, but some may develop the lymphedema at an earlier stage, that is by a week's time. 2 or 3 weeks after surgery also, the patients may start developing the lymphedema. That is mainly due to an extended lymphatic channel, vessel called long arm. So what we call it is a long arm. See, this is the arm, right? So entire lymphatic vessels will be draining into the axillary lymph nodes, right? So in some patients, there will be an extended lymphatic channel that runs towards and it will extend towards the cervical thing. Okay, in those cases, so this arm is compromised because of this channel. The lymph nodes are draining here; it is compromised. But in some patients, they have this extended long arm, so this entire load will be transported via the long arm and it will be taken towards the cervical thing. But it is not that all the patients will have this long arm. Very minimal patients will have this long arm lymphatic vessels. But even that vessel is also, that those patients will also have the tendency to develop lymphedema, because when the lymphatic channels are overloading, it's overloaded, right? So usually it will take around 50 ml, means if it is going to be overloaded and taking 150 ml, then it is an overload. So because of that, at a later stage, the transport capacity within the lymphatic system will be compromised. And again, they are also have a tendency to develop lymphedema. So every patient who has undergone a breast cancer surgery has a tendency to develop lymphedema, even it is an axillary lymph node dissection or a sentinel lymph node dissection or anything. But all the patients are having a high risk of developing lymphedema. Next slide, please. So first we have to know what is lymphedema. So lymphedema is a chronic debilitating condition characterized by abnormal accumulation of protein, water, cellular components, and long chain fatty acids, right? So these are the things which we call it as a lymphatic load. So what is lymph? Lymph is a fluid which comprises of water, protein, cellular components, and long chain fatty acid. See, any components of more than, any cell components or more than 2 carbon atom, right? 2 carbon atom cannot be taken by the venule ends, right? Capillary ends of the venule system. See, the artery is coming and it is diverging into the arterioles, then capillaries. The capillary end of the venous system will take the unwanted thing and it will take towards the heart, right? During this lymphatic channels, the left out of materials like protein, water, cellular components, and long chain fatty acids, which has a larger than 2 carbon atom. They cannot be absorbed by the venular ends of the capillaries. Okay, so these things will be collected into the lymphatic system, because lymphatic system is an open system. It is not a closed system, right? Circulatory system is a closed system. It starts from the heart, goes via arteries, merges as an arterioles, capillaries, then venules, again vein, then goes back to the heart. So this is the closed system of a heart. But the lymphatic system, it just blindly starts in the interstitium and it goes directly and pours into the heart. Okay. These left out particles like protein, water, cellular components and long chain fatty acids, together we will call it as a lymphatic. So lymph. So this is what we will call as a lymphatic load. When this lymph enters the lymphatic system, these particles when it enters the lymphatic system, we call it as a lymphatic load. Okay. When the lymphatic load is larger, when the amount is larger, but the lymphatic channel is compromised because the surgery has been done and the lymphatic channels has been and the lymphatic nodes has been removed. So the transport capacity within the lymphatic system is compromised, right? The lymphatic channels is intact, but the lymphatic nodes is removed. So the lymphatic channels are taking the lymph towards the higher part, but due to the incontinuation, right, discontinuation of the lymphatic nodes, the excess amount of fluid will be retained within the skin itself, because the external lymphedema that we are speaking about is beneath the skin and above the fascia. It is not deeper into the fascia. It is just beneath the skin and above the fascia. That is where the lymphedema in the breast cancer patients will have. Okay, and this lymphatic system will altogether collectively called as lymphatic system, whereas lymphatic capillaries. So these are the parts of the lymphatic system. So it starts as lymphatic capillaries, pre-collectors, collectors, trunks, lymphatic nodes, goes to the venous angle. Right. This is what the lymphatic system is. So that is what that is where I told you we should have a higher knowledge on lymphatic system in addressing breast cancer patients, mainly addressing a breast cancer patient. So how does lymphedema develops? So during breast cancer surgery, the surgeon cuts through the collectors and removes the lymph nodes and the malignant tissue, right? So what happens when we remove the malignant tissue and the collectors? Some collectors remain intact. Okay, that is what I told you about an long arm, but overworked, right? When the load is higher, because of the transport capacity is reduced, okay, then they develop a mural or valvular insufficiency, right? The valvular insufficiency or mural insufficiency is mainly due to the increased load because of the inefficiency of the lymphatic vessels to carry the lymph. Okay, this tends to left out all the edematous fluid in the skin, which we term it as an lymphedema. Okay, this is how the lymphedema starts. Next slide, please. So lymphatic drainage of the breast. As I told, 75% of the lymphatic drainage of the mammary gland mainly goes into the axillary lymph node, right? But the 25% goes into the parasternal lymph nodes, right? This is from the mammary glands alone. But the axillary lymph nodes also drain upper quadrants of the extremity. So the axillary lymph nodes are not only draining only the breast tissue, but also the upper quadrants of the extremity. Entire arm is going to be poured into the lymphatic axillary lymph nodes. The perforating collectors are located paravertebral and parasternal intercostal areas which perforate fascia, thus connect superficial with deep lymphatic system. Okay, as I told earlier, we have collectors, pre-collectors, lymphatic capillaries, everything. There is one section where we call it as an perforating pre-collector. Okay, perforating pre-collectors are the lymphatic vessels that are going to perforate the fascia and get into the muscular layer. Okay, but very minimal amount of the lymphatics is only going into that layer. Okay, next slide, please. So incidence of lymphedema. In worldwide, incidence of lymphedema is estimated about 140 to 150 million of people. India accounts for 40 to 50% of world lymphedema. But in India, the lymphedema, what we are telling is mainly about the filarial patients, right? What we call as an elephantiasis. So those are the patients in India which have a higher incidence of lymphedema. But the same thing, when we compare it to breast cancer related lymphedema, we have about 20 to 50, 56% of breast cancer patients develop lymphedema in India. Next slide, please. So, who is at the risk of breast cancer related lymphedema? So, the patients undergoing lumpectomy in combination of axillary lymph node clearance or a modified radical mastectomy, or combined breast cancer surgery with radiation therapy for regional lymph node, radical mastectomy patients, sentinel lymph node biopsy, radiation therapy to only radiation therapy to the regional lymph node, and breast cancer reconstructive surgeries like tram flap and percutaneous mastectomy. So all the patients who are undergoing for these kind of treatments have a tendency to develop breast cancer related lymphedema. Next slide, please. So how we classify the lymphedema? So usually we classify the lymphedema into 4 stages: stage 0, stage 1, stage 2, stage 3. These are the main classifications of lymphedema, right? Stage 0 is also called as latency phase, because the patient have a tendency to develop lymphedema, right? There will be no clinical edema will be present. Clinically, there will be no edema present, okay? But the patient have a tendency to develop lymphedema, right? As I told earlier, once the lymph nodes has been dissected, all the patients have 100% chances of getting lymphedema. So these all the patients will come under latency phase, okay, where the transport capacity remains sufficient to manage the normal lymphatic load. Okay, no clinical edema will be present. Reduction in fragile balance between the subnormal transport capacity and the lymphatic load will make the patient at a risk of developing lymphedema. As I told, the existing lymphatic channels that are going surpassing the axillary lymph node and going to the cervical thing, those patients will escape from the lymphedema. But even though these patients are also have a high tendency of developing the lymphedema because of the increased lymph node, okay, increased lymphatic load that is going to pour into the existing lymphatic channel, okay. The next stage will be called reversible lymphedema, okay. This is the stage where the patient will have a clinically we will have seeing we can able to see the edematic changes. So comparing the both the arm, one arm will be swollen, okay. Possible to completely remove the swelling, because in these kind of patient there are chances that the entire edema will be reduced, okay, it will be removed while elevating the arm, right. No fibrotic changes will be seen, and pitting of edema will be present but inducible, okay. Next slide, please. And stage 2, what we call the spontaneously irreversible lymphedema or lymphostatic fibrosis. In stage 2, the size of the limb will be increased. So increase in the limb volume, okay. According to that, long-standing accumulation of protein-rich fluids leads to connective tissue proliferation and the production of collagen fiber, which increases in fatty deposits, and fibrotic changes will take place. So see, as I told, the edema that is present in breast cancer patients will be within the skin, beneath the skin and above the fascia, right? So the skin is very much compromised, okay. When the edema is going to be there for a longer time, like months together, we will have an fibrotic changes in the skin because of the longing of the edema, okay. Then a natural skin fold will be increasing. Stemmer sign will be positive. I will tell you what is stemmer sign. And frequent infections or weakened local immune mechanism, which causes cellulitis. Cellulitis is nothing but an infection, okay. But in this edema, when the infection comes in the edematic patients, the entire arm will be swollen and it will have an erythematic thing. It will become in a reddish color. So that is what we call cellulitis. So pitting will be present. The pitting of edema, the pitting will be present, but with difficulty. Okay, the reloading of the pitting will be difficult. Next slide, please. Okay, next slide will be called as stage 3. It is also called as lymphatic lymphostatic elephantiasis. This is the condition where the size of the arm will be extremely big with a high progress of fibrosis and semi-processive. The main thing in lymphostatic elephantiasis patients will have extended external skin changes like fungus formation, fistula, papilloma, hyperkeratosis. Many skin conditions will be there. Those kinds of skin conditions will be starting in the patient. So, and the patients will have frequent infections like cellulitis. And this is the last stage of lymphedema. Mostly, we will have around 10% of the population will get into this stage of lymphedema in breast cancer. But when we go for a venous sufficiency induced lymphedema or an elephantiasis lymphedema or filarial lymphedema, what we call, those conditions, patients tends to develop this third stage at an earlier phase, at an stage of around 3 months or 4 months itself. The patients may get into this bigger edema. Okay, but in upper limb, as of compared to the breast cancer related lymphedema, it has an very decreased effect only. So what will be the assessment for lymphedema? So how we are going to assess the lymphedema? So we will go for assessment of swelling. So how big the swelling is, and we will go to and see the assessment of what are the skin changes. We have to assess the skin changes and what is the severity, and either the patient is having a pain or anything. Next slide, please. So while you are going to assess the limb volume, we will go for circumferential limb measurement. Okay, so this is what we are performing in India. Okay, the measurements will be taken with a non-woven synthetic tape. Okay, we are just going to circumference the arm measurements. We are going to mark some every the measurements will be taken on both the arms. Okay, so that we can able to see the difference between right arm and left arm. Okay, the first point of measurement will be from the knuckles. The first measurement will be taken from the knuckle. The second will be on the wrist. Okay, after the wrist, we will take in 4 centimeter measurements. We will take every 4 centimeter. We will take a mark and we will measure there. Okay, till below 2 centimeters from the axilla, because this area we can't measure. So till this area we will be till this area, like this much we will going to measure. Every 4 centimeters we are going to measure, and we are going to chart it. Okay, then we will be seeing the difference between the right and left arm. Next slide, please.
Excuse me, can you lower your camera a little bit, sir, so that you can show them whatever you're performing?
Okay, done.
Thanks.
So this is what I am using, as this is called a limb volume program. See, because even though after we are just marking down the measurements, we will be unable to calculate it easily. Okay, we have a mathematical formula that we have to do, and we have to calculate, because we have to convert the centimeter into volume. We have to convert the centimeters into ml. So what is the volume of lymph fluid collection is there? So there is a program called a limb volume program. This is developed by Academy of Lymphatic Studies. So where you can see there, right? There is a chart where we can put the measurements of the right arm and the measurements of the left arm. Then just put the calculate. It will calculate and it will convert them into volume in ml. Either it's a 2000 ml, 3000 ml, and it will also give you a graphical representation where what is the difference between this right arm and left arm. Because every 1 week after the treatment, we have to measure the limb volume, and we have to compare either the treatment what we are giving is productively happening to the patient is getting benefit from that. Okay, so this is one program that I am using, and many people used to go put in a formula in the Excel sheet, and they used to do it, but it is very much time consuming. So I'm using this kind of programs. So next slide, please. And this one is the oldest thing, how we are going to displace and see what is the load of edema in the arm. So this is called water displacement method, because we will be submerging the arm in a beaker, and what is the water that is displacing, and we are going to measure that water, and we are going to measure that water, and we will be telling that this limb has this much of weight and this limb has this much of weight. But we can't give an acute thing, and it is not convenient for each patient, right? We have to drain the entire water again, we have to replace the water for other patients. But in circumferential measurements with the tape, it is easy for us to measure. Next limb, please. And this is pyrometer. This is the advanced measuring tool that is available in the market. But in India, we are not having this pyrometer. Here, as you see, the lady is just holding the arm there, and there is one box is there. So it will go in and out. So this is the arm. The block will go in and out. It is having a laser beam which will go in and out. It is non-invasive. It is just the laser beam will mark the external margins of the arm, and it will give a graphical presentation. It will give an even more volumetric analysis and accuracy, so that we can have an 0.001% of difference in the right side and left side. So it is the most highest measuring tool. So next slide, please. So stemmer sign. So stemmer sign, what a stemmer sign is, just we have to raise the skin. Okay, just we have to pinch and raise the skin from the index finger, beneath the index finger, right? You can able to see. So if we are able to pull it up, then the stemmer sign is negative. Okay, we can able to lift the skin, because when the patient develops edema, so the edema is within the skin and above the fascia. So it will be very much hard for the therapist or the persons to pull the skin up. Okay, because of the loaded edema. But when we are able to lift the thing, then it is called as stemmer sign negative. But when you are unable to lift the skin, it is called stemmer sign positive. Next slide, please. So what is the management for lymphedema then? The management for lymphedema, what we call it is a complete decongestive therapy. Okay, so this is the gold standard management for lymphedema, complete decongestive therapy. Or the congestion is there, we are going to completely decongest it. So it has two phases. One is intensive phase and another one is the maintenance phase. Okay, the treatment is called complete decongestive therapy. There are two phases. One is intensive phase, another one is maintenance phase. Next slide, please. So this complete decongestive therapy is the gold standard for management of lymphedema. So this complete decongestive therapy comprises of 4 main components. Okay, skin care, manual lymphatic drainage, compression therapy, and exercise. These are the 4 main components of complete decongestive therapy. Okay, next slide, please. So what is manual lymphatic drainage? The first thing we have to know is manual lymphatic drainage is not massage. Okay, the thing we do in massage technique, what we call is an effleurage, right? In effleurage, we are going to just slowly move the skin along it, so that we can able to see the skin is slowly rolling that. Okay, that effleurage technique. Only technique that we are going to take from that massage thing is effleurage in this manual lymphatic drainage. Other than that, everything will be very minimal and no high pressure is going to apply over the skin. Okay, it is just a gentle manual thing. So it encourages the fluid to away from the congested area by increasing the activity of the normal lymphatics and bypassing ineffective or obliterated lymph vessels. And it mainly happens from proximal to distal. This we have to underline. During massage therapies, we always go to the distal part to the proximal part, right? But in manual lymphatic drainage, what we do is we will go from the proximal part to the distal part. So this is the proximal part and this is the distal part. We will go vice versa. Okay, next slide please. So this is called complete decongestive therapy. So we have phase 1, phase 2. The first thing is intensive phase, second thing is maintenance phase. Okay, but all the components remains the same. One is manual lymphatic drainage, skin care, exercise and compression. Okay, these things will be done in the intensive phase by the therapist, and in the maintenance phase same self self skin care, self compression, self MLD, self exercise. These will be taken care by the patient itself. Next slide please. So in intensive phase, as I told, manual lymphatic drainage, compression, skin care and exercises. These will be done by the therapist. Next slide. So what is manual lymphatic drainage? See, as I told, manual lymphatic drainage have many schools of thought. Okay, there are 4 main schools of thought, mainly Warder, Foldy, Leduc, Cassie Smith. Okay, these are the 4 main schools that teaches lymphatic drainage. So what is called manual lymphatic drainage? Okay, what I am expertise in is Warder technique. So diaphragmatic breathing, proximal to distal, as I told you, slow and rhythmical with gentle pressure. These are the main principles of MLD. Next slide, please. So the skin is slowly stretched, slow repetitive movements is applied with a milder pressure and always from the central to the proximal. Okay, and it is always conducted towards the healthier lymph nodes. Okay, now I'll tell you. The skin is slowly stretched. The skin is slowly stretched and slow repetitive movements, and the pressure is very minimal. As of we are just needing the forehead or an scalp of an newborn. How much pressure we will do? That is the pressure that we are going to apply. Okay, and always from the central to proximal. Central is heart. Here in lymphatic channel, the central is termed as a lymph node. Okay, we should always take everything towards the lymph node. So lymph node is the first part we have to activate, and after that we have to move the entire thing towards the lymph node. Okay, and healthy lymph nodes, as I told, in breast cancer patients the nodes will be removed, so we have to move the entire edematous fluid to the opposite side healthier lymph nodes. Okay, next slide please. Okay, what is the goal of complete decongestive therapy? Is to treat lymphedema, reroute the lymphatic flow, and increase the angiomotoricity. I will tell you what is angiomotoricity, and to create a suction effect and to reduce the limb girth. Next slide, please. So this is how the mechanism of a manual lymphatic drainage works. Okay, it has 2 phases. One is working phase and resting phase. Okay, working phase is that we start, we just slowly stretch and we will give an directional pressure. Okay, then we will have an resting phase, then again a stretch stimuli is applied, and again the working phase and the resting phase. This is the commonest thing. This is how it is going to work. Okay, first a stretch stimulus is going to apply. During the stretch stimulus is applied, the anchoring filaments in the lymphatic capillaries will be pulled. Okay, will be pulled, and the lymphatic angiones will be opened. Due to the directional pressure, the lymph will be entered into the lymphatic system. Okay, the edematous fluid that is collected in the interstitial spaces will be entered into the lymphatic system with opposite direction. Right? This is the only thing, only direction that we are going to put. Okay, no high pressure is needed, because when you are going to give an high pressure, when you are going to knead, okay, this is what we call as a kneading, right? Kneading. When we are going to give an over pressure, high pressure, we will be damaging the anchoring filaments, and the lymph angiones will have a spasm, induced lymphangiosperm. So this is the main reason why we are underlying that we should have a very minimal amount of pressure. Okay, and we should not have any hyperemia, because once we do massage techniques, after massage techniques, we will see the patients developing redness in that area, right? That is due to the increased blood flow to the localized part. Okay, that should not happen in the lymphatic patients. While doing MLD, we should not have hyperemia, because hyperemia is nothing but an increased blood supply to the local part. Okay, but here the patient is already, the lymphatic channels are compromised, and if you are going to need in such a way that the hyperemia is developed, the increased blood supply will, what will happen, it will return an increased venous return. Okay, when the increased venous return happens, there will be an excessive amount of fluid that will be left out in this skin. Okay, so we are going to make the patient even worse. So we should not make the person to have an hyperemia after MLD. Okay, but there are some places where we will be giving some high pressure. Those are the areas are called fibrotic tissue, right? When after the long standing lymphedema like stage 3 or stage 4, what happens is the skin will be fibrosed. In those kind of areas only, we will be applying high pressure. After that, we are not going to give any high pressure over any part of the area. Okay, next slide, please. Okay, so this is what happens in the working phase. While we are going to give a stretch stimuli, the anchoring filaments is going to open, the fluid is going into the lymphatic vessels. Okay, what happens in the resting phase? The lymph vessels absorbs the tissue fluid from the interstitial space, and it slowly moves into the system. See, as this graphical presentation shows, the small arches are there, right? So these are called the lymphatic fragments, or what we call it as an anchoring filaments. This will open and the fluid will get into it, and the valves are going to open and it is going to surpass it. Okay, so the entire lymphatic channel has many number of valves. Okay, segment wise the valves will be present. Okay, during which the movement of lymphatic lymph be inside the lymphatic vessels, we will call it as an lymphangiomotoricity. Lymphangiomotoricity, that is movement of lymph within the lymphatic channels. Okay, that is called as lymphangiomotoricity. Okay, so the resting phase will have for 1 second. Okay, we should not do like this, move. We should do as in slow manner. Okay, that is called 1,000 we have written. So we used to pronounce like this: 1,000, 2,000, 3,000. Likewise, we should take surplus time so that we are not going to rush and we are not going to injure the lymphatic vessels. Okay, next slide, please. So this is what we call an anastomosis. Okay, now I told you how the manual lymphatic drainage should be done. There are many techniques. Okay, I'm just telling you what is the principle of it. Okay, and next to that, already we know the patient has been removed of the axillary lymph nodes. Okay, lymph node clearance has been done, but how we are going to move the excessive lymph to the healthier part? Okay, see in this picture, you can see that the right side of the patient's the left side of the patient has developed lymphedema. Okay, you can see the difference between the arm, right? And there is a surgical scar on the left side also. So think that the left side of the patient has the breast cancer, and the post mastectomy, the lymph nodes has been removed and the patient developed lymphedema. Okay, now the entire lymph has been swollen, the patient developed lymphedema. Now we are going to move this edematic fluid to the healthier lymph node, that is to the right side axillary lymph node, and towards the clavicular node, and to the inguinal node. Okay, we are just going to reroute it. Okay, because it is compromised, the lymph nodes are removed from the left side. So we are going to move it to the healthier part where we can drain the fluid. Okay, so what we call it is as anterior axillary anastomosis, like this. Anterior, so this is the anterior part, anterior axillary, from axilla to axilla, right? And the next part is posterior. Same thing happens in the posterior axillary. Okay, and axillo-inguinal. You can see the arrow marks, right? Axillary, posterior axillary, and axillo-inguinal. Okay, this is how we are going to reroute the fluid. We are just going to take down all the edematous fluid and we are just going to reroute it because the nodes are removed from this part. So we are going to reroute it towards the healthier part. Next slide, please. So this is how we are going to reroute. We are going to take it from here and to the affected part we are not going to touch, so that we are going to just reroute it towards the healthier part. Okay, next slide, please. Next slide. I will show the video later. Next slide, please. Okay, so what will be then effect of MLD? After manual lymphatic drainage, what will happen? There will be an increased lymph production and increased lymph angiomotoricity. As I told, when you are going to do the MLD, the excessive fluid in the interstitium is getting into the lymphatic channel. So we call it an lymph. So lymph nodes has been, lymph production has been increased, and the movement takes place within the lymphatic channel. What we call it is an lymph angiomotoricity, and the reverse flow of the lymph will be stopped because all the valves in the lymphatic channels will be activated, and the increased venous return. At the end, all the lymphatic fluid will be goes into the venous system only. So, and it will also give an soothing and analgesic effect. Okay, next slide, please. Okay, so this is how after lymphedema management, you can see, right, this lady has this bigger arm of her left thing. Then after management, how it has been changed. Next slide, please. Next slide, please. Okay, now we are going to cover compression therapy. So now we have seen only one part of complete decongestive therapy, that is called manual lymphatic drainage. The second part will be compression therapy. Okay, so just a second, I will show you a video. Just a second, I will just show you a video. And
then I have to stop sharing then.
No, you can. No, they can see my.
Because,
yeah, they can see my video sensor.
Manual lymph.
Do you want to stop sharing? They can just see my.
Anything as you wish.
Yeah, they can see my screen. If you can able to see it, then they can able to see it also. Just a sec, I'll just on it off. So can you able to see it?
Yes, I have stopped it, so it's easy for everybody to see that.
Okay, I'm just playing it on.
Drainage, MLD, is a gentle manual treatment technique that makes four basic water strokes: the stationary circle, pump, scoop, and rotary. Stationary circles can be used on any part of the body, while some strokes are used for specific parts of the body, such as flat surfaces, back or chest, or rounded surfaces, arms or legs. Also, a combination of these strokes can be used to increase effectiveness, such as pump with stationary circle, which is referred to as pump push.
Can you lower down the screen a little bit?
Performed either in a stationary pattern remaining in the same position,
Or can you lift
or
up
in a
the
dynamic
camera,
pattern,
Nyanashekhar
which
sir?
involves movement of the hands towards the specific. Strokes are performed using one hand or bimanually using both hands. The goal of manual lymph
We could
drainage
see the
is to
keypad.
route lymph
Can you lift up the
from
camera a little more?
involved areas into more
Ah,
centrally
yes,
located
little
healthy
bit.
lymph vessels, which drain into the venous system.
Or else you can put the back camera and show them.
The common denominator in all strokes is the working phase and the resting phase. In the working phase of a stroke, stretch stimuli are applied to the subcutaneous tissues, resulting in the manipulation of anchoring filaments of lymph capillaries and the smooth musculature in the wall of lymph angions. The light directional pressure in the working phase also serves to move lymph fluid in the appropriate direction. The pressure is released during the resting phase, in which the elasticity of the skin moves the therapist's hand passively back to the starting position. In this pressure-free phase, initial lymph vessels absorb tissue fluid from the interstitial spaces. To achieve maximum results, each working phase should last 1 second and should be repeated 5 to 7 times in the same area in either a stationary or a dynamic pattern. It's also performed using light directional pressure. The pressure should be sufficient to stretch the subcutaneous tissue against the underlying fascia to its elastic capacity. It's not necessary to apply high pressure to achieve this goal. In fact, too much pressure could damage anchoring filaments or other lymphatic structures, or cause lymphangiosperm in lymph collectors. The amount of pressure is sometimes described as the pressure applied while stroking a newborn's head. However, more pressure is needed if fibrotic tissue is present. Manual lymph drainage is often called a light touch massage, but it's not massage. The word massage means to knead from the Greek masso massein, using considerable pressure, and is used to treat ailments in muscle tissues, tendons, and ligaments. Manual lymph drainage, on the other hand, consists of very gentle manual techniques designed to have an effect on fluid components and lymphatic structures located in superficial tissues such as the skin and subcutis. Manual lymph drainage can be used to treat various different ailments, but it's also one of the 4 components of complete decongestive therapy, CDT, which is considered the gold standard treatment for lymphedema patients.
Hello. Sorry, I don't have this video in my thing because it is have a higher resolution. So that's why I shown you like this way. You can share your slides, bro.
Okay then.
Right. So till now, what we have seen is just manual lymphatic drainage alone. That is the one component of CDT. And the next thing we are going to see is what compression therapy. So this is the second phase of treatment. Okay. In this phase, after MLD, we will be applying compression therapy. So here, what we call it as an multi-layered lymphatic bandages. Okay, MLLB. So it has we can use the compression in many forms like the compression garment, bandages, and bandage alternatives, and uses of compression garments along with bandages likewise. Next slide, please. In this kind of edematic patients, we use an specific bandage called short stretch bandage. I'll tell you in the later slides. And what will be the effect of compression? The effect of compression will be reduced filtration increased reabsorption, and prevent reaccumulation of lymph, and improve efficiency of joint and muscle pump. So these are the effects of compression. Next slide, please. So what are the types of bandages? So these are the two main types of bandages, in which short stretch and long stretch. But where we use here in lymphedema patient is called short stretch bandages. These normal orange color bandages we call this a long stretch bandage or grape bandage, because short stretch bandages have high working pressure, low resting pressure, stretches from 30% to 60%. Okay, where in long stretch it has low working pressure with high resting pressure, and stretches 150% to 300%. So this is the main difference between these two types of bandages, and we will be using this bandages alone, short stretch bandages alone. Next slide, please. And here in India, we doesn't have a manufacturer for short stretch bandage. Okay, so what is this resting pressure and working pressure? So resting pressure is that the bandages or compression garments applied on a constant pressure to the skin when the limb is at rest. Okay, what is working pressure? When the muscle contracts and expands, they press against the resting bandage, and the pressure inside the limb increases temporarily. So this is called working pressure. This is why we prefer short stretch bandage, because it has high working pressure and low resting pressure. Okay, next slide, please. So this is how we are going to apply the bandage. So while applying the bandage, it usually starts as an inverted cone. Okay, so this area we will have an lesser conical part, and slowly we will be developing it. Okay, a smaller radius to an higher radius. Okay, usually it starts from 4 centimeter bandages and we ends up to 10 centimeter bandage. Next slide, please. What are the parts of the multi-layered bandages? So we have finger bandages, tubular bandages, soft synthetic wool, dense foam, inelastic and elastic bandages, adhesive tapes, and complex foam. These are the parts of the bandaging techniques. Next slide, please. So first we will apply a tubular bandage just to cover the skin, and on top of that we will be covering the fingers, and after covering the fingers we will be putting in foam, that is a cotton foam, and on top of cotton foam we will be applying an high dense foam, and on top of that only we will be applying the short stretch bandage. Okay, next slide, please. Just a sec, I will show you in another video. I'll just try to I'll just show you in video. Can you able to see this?
Yes. If your
So
mobile
here,
goes little down, it would be fine. Your mobile.
is it okay?
Little down.
Okay.
No, not like that. Just, yeah, little up would be fine.
Just a sec. Yeah. Is it okay?
Little more.
Right?
Little up, sir. I think you can use your back camera so that you can view it correctly, no?
Yeah, I'm using my back camera only.
Okay.
So these are confidential videos that we can't share. So that is the reason I'm using it on this. So this is how the finger bandages are applied. After after tubular bandages, we will be covering the entire fingers. Then on top of this, we will be applying the foam. So this is what we call as foam
Camera
pad.
has to go little up. Yanashikar, camera has to go little up. Yeah.
This is okay?
Yes. Yes. Now, yeah, this is fine.
Done. So then we will be applying this foam bandages, because the patient has to wear the bandage for the entire time of around minimum of 20 hours. So they should be on top of compression. Okay. So if you are going to apply the short stretch bandage directly on the skin, the patient will have an discomfort. So for that reason, we will be using a tubular bandage to prevent the skin from any erosion. On top of that, we will be giving foam padding, and on top of that foam padding only, we will be giving the short stretch bandages. So this is for short stretch bandage that we are applying, because when the area is smaller, so that the radius is smaller, and we are applying with the same pressure, when you gradually the radius is going to increase. So that is what we call as an inverted cone. In an inverted cone, in the tip or in the lower part, the radius will be very much small, and gradually the radius will be increased. Okay, but when you are applying the same even pressure towards the entire thing, where the radius is very small, the patient will have a tendency to develop uh, an increased pressure inside the part. Okay, so when it is, you can share the slide, bro. So when we have an inverted cone, the tip of the thing will be having a lesser radius. Okay, gradually when the radius is getting big, so like an inverted cone, the lesser radius part where the bandages are applied will generate more pressure because of the lesser radius. So gradually it will be increasing. So it is not necessary that we should stretch and we should tie it. We should just gently roll it on. Okay, as the inverted cones goes slowly, the pressure will be increased gradiently. Okay, so this is how it goes. And in maintenance phase, self MLD, self bandaging, skin, hair, and exercise to be taken care by the patient themselves. Next slide, please. So these are the bandage alternatives, because after treatment, after the intensive phase is over, the patient goes for maintenance phase, where in maintenance phase, patients are not, some patients may not able to uh, tie the bandages regularly, and some patients may need not have to tie the bandages, because the edema will be reduced so much, so that they can just wear the compression garments and just maintain it. Okay, and the bandage alternatives, there are many types of bandage alternatives. I will just show you. Next slide, please. Like compression stockings, ready wrap, these many kinds of bandages alternatives are there. See, the first blue thing that is showing is called a Jovi pack. So that is an entire dense foam layer stitched stockinette like thing that we used to give to the patient, just to on top of it we can just bandage only in the night time. Okay, and next to that bluish thing is called ready wrap. So it is specifically designed for night garment. Only on the night time we can use this, because in this particular garment the pressure will be reduced, the pressure gradient will be less. Okay, the next thing you can see is this compression stockings. So this should be worn on the morning when the arm is in the against gravity position, because the arm is dropped down, the edematic fluid has to come up. Okay, so that by the time we need high pressure, so we will be giving this compression arm sleeve. or compression arm stockings. Okay. The next thing you are seeing is a glove. Okay, specifically glove. It is designed for the patients who has some edematic in the fingers and in the hand. Next slide, please. So what are the contraindications? What are the contraindications means when and all we should not give CDT. When the patient is having cardiac edema, chronic heart failure, coronary heart failure, and acute infections like cellulitis, renal failure, acute bronchitis, bronchial asthma, malignant lymphedema. In these kind of patients, we should not give complete decongestive therapy, because in these conditions already the patient's limb volume will be compromised. Sorry, cardiac volume will be compromised. Okay. In those conditions, when we are going to increase the volume towards the heart, then it is going to create an more stress to the heart. Okay. What is about this acute bronchitis and bronchial asthma? So these acute bronchitis and bronchial asthma patients, these are mainly due to this innervation of this sympathetic nervous system. Okay, parasympathetic nervous system. The same nervous system will be facilitating the lymphatic flow also. Okay, so when these kind of system is also compromised, we should not induce stimulation, and again the patient will get into more trouble. Okay, next slide, please. Okay, exercises after breast cancer surgery. What are the exercises that the patient should perform after breast cancer surgery? Next slide, please. The main effects that we are tend to give is to get the arm and shoulder to get a normal range of motion, to decrease the side effects of the surgery, and to decrease pain and stiffness, so that the patients can get back to their ADL. Next slide, please. So immediate post-operative day, either it is a radical mastectomy or a modified radical mastectomy or a complete mastectomy. So this is the protocol that we used to start. Day 1 and day 2 depends upon the type of surgery and the pain sensitivity of the patients. We will include shoulder rolls, elbow exercises, and wrist exercise and hand exercise. We will not take the shoulder and full arm, just shoulder rolls, just shorter exercise likewise. Okay. On day 3 onwards, we go for shoulder stretch. Slowly we will stretch the shoulder, and slowly we will increase the range of motion. We should have an wide knowledge that the patient will be having a surgical scar from here to here. The clips will be there, or the sutures will be there. On doing exercise, we should not pull off the drain tubes. 2 drain tubes will be inserted. So we should have more conscious on doing exercises. Okay, next slide, please. Then ball squeeze on seated and elbow flexion extension on seated. Okay, now you can see this, the patient is having an stockings, right? You can see, right, the patient is wearing a stockings. So after surgery, if the patient develops lymphedema, all the exercises should be done with a stockings or a compression thing. Okay, we should not directly do the exercises. Always they should be on top of compression. Okay, but when the patient is admitted in the hospital on post-op day 3, 4, 5 up to 7, need not go for a compression, because the patient is having a drain tube and a surgical clips will be there. So no need for compression on that time. Followed with that, when the clips will be removed at the days of around 8 to 10. On 8th day, I believe, according to the patient's character, mostly on 8th day, the doctors go for alternate clips removal. So during alternate clip removal, give 1 day rest, and the next day you can start again the same regime of entire shoulder movements, elbow and wrist, and followed by 12th day or 13th day, they will tend to remove all the clips. When all the sutures will be removed, you give rest for 2 days, and on 3rd day again you can start the entire regime. Next slide, please. These are commonest exercises that all we do for patients, that shoulder horizontal abduction, adduction, and elbow extension with floor exercises. And we can give them a mild dumbbell of around half kg or anything, and on standing shoulder abduction and standing shoulder flexion extension. Next slide, please. These are the commonest exercises, things that we used to give, and wall climbing exercises, those kind of things. Next slide, please. Okay, during chemo and radiation, for the general active range of motion, deep breathing exercises, and increased radiation um, during radiation and all, we should make the patients to perform more breathing exercises, because we are irradiating in the breast part. So if this part is going to just constricts and it is going to create an heftiness, the patient may unable to breathe properly. So breathing exercises are main, along with the general bodily movements and walking, those kinds of things. Next slide, please. And for lifetime, all the patients should have an upper limb active range of motion exercises. They should do the active upper limb range of motion exercises towards their entire lifetime, and graded strengthening exercises like with a minimal of dumbbells and things, and low to moderate intensity of aerobic exercises they can start, and yoga, mild stretching exercises they can do for their pectoral thing. Next slide, please. Okay, done. See, on the beginning itself, I have told you, I believe some of you will remember, I have mentioned deep breathing exercises and diaphragmatic breathing exercises. Okay, on the first component itself, I told you diaphragmatic breathing exercises, but I haven't explained it. Okay, diaphragmatic breathing exercise plays a vital role in reducing the edema. See, how you can interact, how you can incorporate that, how diaphragmatic breathing exercise is going to reduce lymphedema. Just think for a second. Okay, see, as I told you, lymphatic system is not an closed system, it is an open system. It opens blindly in the interstitium and it pours into the heart. Okay, see, circulatory system is a closed system, from heart to the cells, and again from the cells to the heart. It's a closed system. While doing diaphragmatic breathing, what we have is the largest duct, we call it as a thoracic duct. Okay, the thoracic duct just pierces the diaphragm and it comes upward. Okay, during this diaphragmatic breathing exercises, what will happen is the thoracic duct will be pierced. During this diaphragmatic exercise, what tends to happen is the duct will be squeezed. Okay, when the duct is squeezed, we have a tendency to develop a suctioning effect in the duct. Okay, what happens when the suctioning effect in the duct starts? It pulls the volume of the fluid upwards. So as such, that heart pumps and it will just pulls the fluid inside. Here, the thoracic duct will just squeeze and it will open, so that fluid will be pushed inside it. It will be pulled up. Okay, this is the main reason that we used to tell the patients to go for a diaphragmatic breathing exercises. Okay, and you can start your questions. You can just pin in your
Thank
questions.
you so much, Nyanashika. That was a splendid presentation,
Thank you,
which we are not much explored most often. And I request all the participants to put up your questions, if anything is there in the chat box, and I think I can ask you some of the questions which was in the
Yes,
chat box
yes.
earlier.
Yeah, I will just open the chat box now. Okay, in call messages. Okay.
First question was like, sir, toddlers, what is the risk of getting cancer at this age?
See, we can't predict the cancer. We can't predict. Okay, brother, you can just start the questions. I can just answer you. Rather than me reading the questions, you can just tell the questions. I can read it and I can just explain to you. See, for a prediction of cancer is very less. We can't predict that one patient will develop cancer and another patient will not develop cancer. Likewise, okay, the cancer is a disease like anyone can develop it. Okay, it is a genome thing that under research. So it is not that only the toddlers will develop. Even a newborn is getting. I have seen patients of 6 months old newborn, a toddler who has a cancer of renal kidneys, and an 8 months old who has a leukemia, and at age of 90, a patient has came for a colon cancer. So we can't predict. So this we can't predict, and we can't give you a particular sign that these patients will 100% develop cancer and these people will not develop cancer. So everyone are at a risk according to their social status, socio-economic status, and the place they are, the environmental thing, and the food we intake, the air we breathe, and the genetic hereditary thing. So anyone are at a risk of thing. So that's why we usually say, so take healthy food, so have some good exercises, keep your body moving, so those kinds of thing. Next question.
Okay. Ms. Soumya has asked you about in which muscles we do the DAP technique.
It is not that the DAP technique should be used on a single muscle. The entire arm we will be using. As I told, usually it will start the thickening of the lymphatic channels we can see from the wrist, from the bottom of the wrist, from the base of the thumb, wrist, towards the cubital fossa, and towards the axilla. Okay, from the entire part you can see a cord like thing. Virtually, while you just palpate the patient, while palpating the patient, virtually you can feel a cord moving like this. Okay, so in that part only we are going to stretch it off. It is not a particular muscle. We are not concerning about the muscle, because we are not going to need the muscle. We are just needing the lymphatic channel that has been fibrosed.
Actually, Mr. Amit Kumar was asking about the causes of childhood breast cancer.
See, as I told, we don't have a specific cause for a childhood breast cancer or anything. We don't have a specific cause. I have seen patients who has around 16 years old girl who has breast cancer. We removed her breast because of an extensive thing, because she had an hereditary that her grandmother had cancer. And on the same thing, we have seen other patients also who doesn't have a family history and developed.
Hello? Can you hear me?
Hello, is it audible now?
Yes. And Ramakrishna has asked you, like, sir, how do you get certification in CLT course? Can you please tell us the details and fee
Yeah,
details?
sure, I can tell you. See, certified lymphedema therapist is a course. It is around extensive 10 days clinical training, actually 9 days clinical training. And before that, we have to clear some of around 8 to 9 online exercises. Online testers will be there. We have to clear those things, and followed with, after clearing the online thing, we will have given a certification that you have cleared all the online classes. Then you will be introduced to the practical session. On the day one itself, you will have you will have another exam on the day one, followed with practical sessions will start. And on day 9, again you will have a clinical and theoretical exam. And completion of that only will be giving the certification. Here in India, we doesn't have a course. Okay, but in US, UK, other countries, we have this. I told you, right? Water, full D, Cassie Smith, those can buy. So they are having some short course, the minimized version of an um, a CLT course, but it is not a CLT course. It is a course called. I can't frame it as a course, but I don't know what term they are using. But you will not be considered as a certified lymphedema therapist unless until you get certificate from this 4 schools I told, because these 4 schools are only authorized by the LANA. LANA is called Lymphology Association of North America. So that is the sector which approves and authorizes the persons that you are a certified lymphedema therapist. Other than that, many people are taking some few classes or anything like that. So we can't take it as a full course. And Tata Memorial Mumbai, they are having a course of around 4 days, something like 4 days or 5 days. I don't maybe 4 days, but it is not that extensive course as I told, where you can have some idea on it.
Okay then. Miss Jessica, yeah, Miss Jessica Fernandez has asked you, in interior axillary drainage, how exactly do we cross the midline? It won't affect your heart or lung.
So it is not going to affect our heart or lung because, as I told you earlier, the edema that is present in this lymphedema patients are just above the fascia, below the skin. So we are not going to use this perforating precorrectors to just pull it inside. So mostly we will be mostly we will be just pulling it over like this. You just push it over. Axillary or posterior axillary or axilloinguinal. So we will be not perforating it. Mostly we will just pull it over.
And Ms. Jessica has also asked about any evidence of breast cancer being caused due to excess cell phone use or deodorant usage.
There are many studies. There are many studies that this deodorant means this roll-ons are there, right? So some patients are affected because they had a tendency and they have an allergic reactions that develops as an rashes, followed with the rashes that develop into an necrotic thing, followed with that was become malignant. So many things are there. See, as I told, not every person are prone to it. Okay, some people are tend to have that, and many studies are there. I believe many studies are there, but that is not applicable for all patients, all persons.
Ms. Neetu has asked about is it necessary to wear compression bandage while doing exercise?
Yes, it is mandatory because when the muscle is moving, when we are going to do an exercises, when the muscle is getting pumped, okay, it is going to pressurize and push out all the fluids outside. Okay, it is going to pressurize out. But when we have an compression garment, that compression garment will give an external force, okay, external pressure, where this it will be sent into the lymphatic vessels. That is the reason mainly we should wear a compression garment during exercises.
And again, Ms. Jessica has asked, is there any difference in rehab in breast cancer for men as compared to women?
No difference. See, men around only 5% of men or below 5% of men only develops breast cancer. Okay, when it is considered as a breast cancer, the treatment protocol remains the same, rather of age, gender or anything. And the clinical profile of the patient, according to the clinical profile of the patient, that the regime remains the same.
And Mr. Betty Sam has asked, like, is bandaging is only at night time?
No, actually during the intensive phase of treatment, the compression bandages should be applied from the morning towards the entire night. So the next day. So I told you, right, minimum of 20 hours the bandages should be on. Okay. And during the maintenance phase, the patients can use the compression garments at the morning time, and at night time they can use the bandages. And even during night time, they can use some compression alternatives. As I told you, Ready Wrap, Jovipac, many compression alternatives are there.
And Ms. Ezana Ansari, he has asked about, like, can we use moist heat for severe shoulder stiffness for patient who
I
has
have to
undergo
underline
radiation
this.
therapy?
I have to underline this. Just a minute. I will just have some water. I have to underline this because
She has also asked, like, some mobilization was used for that patient to improve range of motion, and also shoulder range of motion was severely restricted for that patient. I think she is
sure.
discussing about her patient something.
Okay, now I'll tell you. See, no hot and cold modalities. See, any modalities that is going to induce hyperemia, we should avoid those modalities for the patients, because as I told, uh, induced hyperemia, when you induce the hyperemia, there will be an increased vascularization and an increased lymph load. Okay, so we should not use, underline this please, we should not give any modalities that is going to increase the hyperemia. Okay, no hot or no cold.
Even the electrical modalities, I hope.
Yes, even the electrical modalities, but we can use TENS, transcutaneous electrical nerve stimulation, to avoid pain alone. That to an particular extent. But I have recently published a paper in addressing a patient who has an breast cancer, who has an same side of shoulder stiffness. The patient also had lymphedema, but due to this patient has some frozen shoulder. Because of that, the patient is unable to lift the arm, entire arm. The ROM has been restricted. What I have done is I have given matrix rhythm therapy to reduce that shoulder, to increase the shoulder ROM. But I have always compromised the increased vascularization with MLD. As I know how to deal with MLD, I have administered matrix rhythm therapy to just get back the range, and followed with every session of matrix rhythm therapy, I have given MLD. See, like that, if you have the capacity to mask that hyperemia, you can able to use it. But deep heat modalities should be avoided. Moist heat modalities should be avoided. Confirm. We should not trial practice with the patients, because I have seen many patients, around 12 to 13 patients, because of the physiotherapist, we unknowingly, it is not known, because as we are not taught, right? Because unknowingly they have given wax bath to mobilize the patient. Okay, because post treatment, the patient has developed a painful shoulder stiffness. For that, the patient has been to the physiotherapy center. They have given wax bath to mobilize. So that is a normal thing that we do. But in this case here, because of this breast cancer, they have developed cellulitis. Okay, I have seen many patients like this. So avoid moist heat modalities, either cold or hot. Avoid deep heat modalities, and have an cautious thing while handling a breast cancer patient.
Excellent. And the final question is about, like, Ashvi Takkar is asking about how can we make an awareness, a spread of awareness among the physiotherapists regarding the breast cancer and its management.
That is truly according to the therapist knowledge and need. Actually, what I am doing is personally, I have organized many international conferences and national conferences, many symposiums, just to enlighten the students to know the role we play in oncology, and the role how we should handle it. It is purely according, when the subject goes on. Okay, it is not only in India we are facing this problem. I have been to many other countries, in UK, New Zealand, Australia, Canada. Only a specific group of physiotherapists, as in India, we know how to handle the oncology patients. Okay, now what we can do is, we can start with this universities and the colleges to bring at least 7 days or 10 days clinical classes for the students, at least for the outgoing students, like final year students, to have a note on it. So it is purely on education alone. Apart from that, we can't do anything.
Okay, thank you so much. And
Sure,
I
sir.
request Ms. Sumaya Fatima, a physiotherapist, to deliver the vote of thanks. Fatima Sumaya. Yes.
Good evening, all. The webinar was so informative and it had imparted a great deal to add up our knowledge and expertise. On behalf of CRC Kozhikode and Department of Physiotherapy, I extend our immense gratitude to Mr. T.V. Gnanashekhar sir who accepted our invitation and presented the topic in most simple and best way. I owe our thanks to all the participants who wholeheartedly attend in the webinar. We hope that this webinar has added up more to your knowledge, and we look forward your presence in future webinars. We also thanks Mr. Jidin, our library in charge, for providing the technical support and advice. And this is Fatima Sumaya. Thank you.
And one more thing I have to tell you. And usually, what we have studied for edema management in our electrotherapy classes are we use it called as Faradism under pressure, right? I believe some people will remind those things. So we call this a Faradism under pressure. In that, we will stimulate the muscle pump with applied over and bandaging thing, right? That thing we should not apply to the lymphedema patients, breast cancer patients, because there is no compromisation of any muscle related issues. The patients can ultimately they can just create that muscular pump, okay, and no need for electrical modalities to stimulate the pump. So that is the reason for not encouraging Faradism under pressure to the healthier patient. Okay. Thank you, brother. Thank you for giving me this opportunity to share this thing, because October month is called as an breast cancer awareness month. In this month, you have given me a session for this to enlighten the fellow physiotherapy community about this breast cancer thing. I want to thanks your HOD Pino Matthew sir for accepting me as an lecturer to enlighten you with this thing. Thanks a lot for this.
Oh, okay. Thanks a lot, Jnanashekhar. And it was very useful for the physiotherapy community as a whole, because very rarely people are there who could have excelled in such a rare area, because palliative and cancer rehabilitation is in the say preliminary stages in India. So I hope this knowledge will help them to grow in that direction. And I thank Jnanashekhar for using this opportunity and helping us to reach the people. And thank you once again. And I thank all the participants, and kindly please fill in the feedback form, because that will be used for providing you the certificate. And we are looking forward to meet you all in our future webinars, and we will be coming up with topics which will be quite interesting, and it will enlighten your domain. Thank you.
Thank you. Thanks a lot, sir. So I'll be disconnecting. Thank you all the participants.
Yeah.
For taking your valuable time and listening to this. Thanks a lot. And I have given my mail ID in my last slide. You could have seen. And if you need any assistance, you can just mail me. Thanks a lot.
Sure.
Thanks a lot, brother. Thanks a lot.
Thank you, Jnanashekhar. Thank you.